Welcome to our educational journey into the fascinating yet often challenging world of neurological disorders. Today, we'll be focusing on a rare neuromuscular condition called Endplate acetylcholinesterase deficiency. Join us as we explore its origins, effects, diagnosis, and management. Endplate acetylcholinesterase deficiency is primarily caused by genetic mutations. These mutations occur in the CHEL gene, which provides the instructions for making a protein called collagen Q. Collagen Q is essential for anchoring acetylcholinesterase, the enzyme responsible for breaking down acetylcholine, to the neuromuscular junction. When the CHEL gene is mutated, it leads to a deficiency or dysfunction of this anchoring mechanism. This leads to prolonged acetylcholine activity, disrupting the normal transmission of nerve impulses to muscles. Let's delve into the pathophysiology. The neuromuscular junction is where a motor neuron communicates with a muscle fiber. Acetylcholine, a neurotransmitter, is released from the motor neuron, crosses the synaptic cleft, and binds to acetylcholine receptors on the muscle fiber. This triggers muscle contraction. Normally, acetylcholinesterase rapidly breaks down acetylcholine, allowing the muscle to relax. In Endplate acetylcholinesterase deficiency, the enzyme isn't properly anchored, resulting in a reduced capacity of the enzyme to carry out its function. Acetylcholine lingers for too long, overstimulating the muscle fiber. This prolonged stimulation disrupts the delicate balance needed for normal muscle function, leading to weakness and fatigue. Because Endplate acetylcholinesterase deficiency is caused by a rare genetic mutation, it is an extremely uncommon disease. Precise figures on its prevalence are difficult to obtain, with only a small number of cases reported worldwide. It tends to affect individuals of all ethnic backgrounds and manifests mostly at a young age. The signs and symptoms of Endplate acetylcholinesterase deficiency typically manifest in early childhood, though onset can vary. A hallmark symptom is muscle weakness, particularly affecting the limbs and face. This weakness may fluctuate, worsening with activity and improving with rest. Infants may present with fluffy baby syndrome, characterized by reduced muscle tone. Other symptoms include difficulty feeding, delayed motor milestones, ptosis of drooping eyelids, and facial weakness that manifests when smiling or crying. In some cases, individuals may also experience respiratory difficulties or scoliosis. Diagnosing Endplate acetylcholinesterase deficiency requires a combination of clinical evaluation and specialized testing. The process begins with a thorough medical history and physical examination, carefully noting any muscle weakness or fatigue patterns. Electrophysiological studies, such as electromyography at EMG and nerve conduction studies, are crucial. These tests help to assess the electrical activity of muscles and nerves. Single-fiber EMG can reveal characteristic findings indicative of neuromuscular junction dysfunction. Genetic testing confirms the diagnosis by identifying mutations in the CHEL gene. Muscle biopsy with specialized staining may show alterations in the Endplate region of the muscle fiber. While Endplate acetylcholinesterase deficiency itself doesn't have distinct classifications or types in the traditional sense, the severity and specific symptoms can vary considerably between individuals, depending on the specific CHEL mutation and other modifying factors. Currently, there is no cure for Endplate acetylcholinesterase deficiency, so management focuses on alleviating symptoms and improving quality of life. Medications, such as anticholinesterase inhibitors, which are commonly used in myasthenia gravis, may be used to temporarily improve muscle strength in some cases. However, these medications aren't always effective and can sometimes worsen symptoms. Physical therapy plays a vital role in maintaining muscle strength and preventing contractures. Assistive devices, such as braces or wheelchairs, may be needed to support mobility. In cases of respiratory difficulties, respiratory support, such as mechanical ventilation, might be necessary. A multidisciplinary approach involving neurologists, geneticists, physical therapists, and other specialists is essential for comprehensive care. As Endplate acetylcholinesterase deficiency is a genetic disorder, there is no way to directly prevent its occurrence. Genetic counseling is recommended for families with a history of the condition. This allows prospective parents to understand the risk of having a child with the disorder and explore available reproductive options. The prognosis for individuals with Endplate acetylcholinesterase deficiency varies depending on the severity of the condition and the effectiveness of management strategies. Some individuals may experience relatively stable symptoms with appropriate supportive care, while others may face progressive disability. Recent research efforts are focusing on developing gene therapies that could potentially correct the underlying genetic defect. While these therapies are still in early stages of development, they offer hope for future treatments. Understanding the long-term effects of different CHEL mutations and identifying factors that contribute to symptom variability are also areas of ongoing investigation.